Welcome, everyone, to today's session of our survivorship series, Sexual Health in Young Adult Cancer Survivors, led by Lydia Chevalier. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the session over to Dr. Chevalier.
Perfect, thank you. All right, so I'm excited to be here today. Thank you all for joining us. I'll be talking about sexual health in young adult cancer survivors. And just for some context, so I'm a clinical psychologist at Dana-Farber. I work in the sexual health program, and I actually specialize in sexual health in young adult cancer survivors. So you'll see a little bit later, I've been doing some research in this area, as well as my clinical work that we'll be talking about today. All right, so first, what is sexual health? I think this is a big question, and sex is so often talked about in the media. It's in all the movies and every TV show that you watch, but we don't actually talk about sexual health that much. The really important piece is that sexual health is not just physical. We know that there are physical components to it, but it's really made up of what we think of this biopsychosocial model. We'll be talking about that in relation to kind of what does that mean for you. But basically, we know that there are all of these biological or physical factors. So things like hormones, particularly after cancer, there's a lot of changes to hormones, to physical health. There may be things like genetics, there could be pain, fatigue, disability, things like that. Those are all going to really affect sexual health. But we also know that it's not just those pieces. We know that the social and the psychological are equally as important. So especially when we're thinking about aspects of sexual health, like sexual desire, it's going to really matter what's going on in the rest of your life. It's going to matter if you're anxious or depressed, or if your stress is really high, you're maybe not going to be as interested in sex. And also for young adult cancer survivors, the social piece is incredibly important. So I work with lots of people who have never dated before, and they're terrified of having sex after cancer because they don't know what it's going to be like, and they're scared to have that experience with a new person. And so all of these different components are really, really important, and they're all related. So we're going to be talking about all of these aspects today. So what does sexual health look like in young adult survivors? Because all of those different components, those apply to anybody. That applies if you get diagnosed with breast cancer in your 70s, and it also applies to anybody who got diagnosed kind of earlier in life. But specifically, what does it look like for young adult survivors? So we do know there's a lot less research with this group, but we do know that young adult survivors have a wide range of sexual health concerns. And we'll be going through exactly what this means, but some of it is what we call sexual dysfunction. So we think of that as kind of vaginal dryness, more of those physical symptoms. But we also know that there's all of these other changes like low sexual desire, lack of knowledge or experience. As I mentioned, lots of folks in this age group just haven't had any sexual experience. They haven't had dating experience. They're not sure how to, which we'll be talking about. And then what we call psychosexual concerns, so body image and things like that. So let's start with the physical piece. We know that unfortunately, the good news is most young adults who have cancer and were diagnosed earlier in life do survive. But we do know that those drugs and those surgeries and the radiation have really intense late effects. So they have really intense physical effects kind of later in life that can last for years. And one of these is unfortunately sexual health dysfunction. And so unlike other side effects like fatigue often or nausea that resolve on their own, we really know that these sexual side effects don't go away on their own. The good news is they're treatable. The bad news is they won't kind of just disappear overnight. So specifically what happens? When people have chemotherapy, radiation, and surgery, specifically remove of their ovaries, it's kind of one of the things that makes the most difference for female survivors. There can be a lot of changes to the ovarian function. And the ovaries are really important for things like creating estrogen. And estrogen is very important for our vaginal health. So what happens is there are lots of estrogen receptors in that vaginal tissue, and that's really important to keep the tissue kind of healthy, stretchy, elastic, and moist. And when the estrogen changes because of all of these different types of treatments, what happens often is that there's a reduced blood supply, and so people will often notice changes such as decreased lubrication. So they're just not getting that kind of natural lubrication that they're used to. Another thing that can happen is something called vaginal dryness. And so this is when that vaginal tissue, because the estrogen isn't in it anymore, gets kind of fragile and dry. And it can be really painful. It can be kind of a burning or a tearing pain. Very, very painful and a very specific type of pain. And so that's really because that tissue is dry, and we'll talk about treatments, but it is treatable. What we need to do is we need to use a moisturizer that is specifically formulated for that tissue. So there's two different broad types of moisturizers. One of them is what we call a non-hormonal moisturizer. This is something you can get at like CVS, over the counter, and it has a lot of the same ingredients as moisturizer that you would use on your face. So for example, hyaluronic acid, but it's designed for the vaginal tissue. So it's pH balanced. So that is really, really helpful for getting moisture back into that tissue. The second option for a moisturizer is something called vaginal estrogen. And this is because, again, that estrogen is leaving that tissue. And so we need to put the estrogen back into the tissue to help it heal. And so this is moisturizer. It's very similar to those other moisturizers, except it also has vaginal estrogen. And so the estrogen really just stays in that area and helps make that tissue nice and healthy. So again, lots and lots of changes can happen. We'll be talking about some other ones, but kind of these are the physical pieces, is that you might have changes with lubrication, you might have vaginal dryness, it might be harder to reach orgasm. So again, that's related to the estrogen. Just kind of the threshold for orgasm just rises, and it's just harder to get there. And then all of these things can lead to pain with sexual intercourse. So this is kind of just a quick overview I want you to know, so that if any of these things are happening, feel free to reach out to the sexual health clinic. I'm happy to see you to talk more specifically about what might be happening for you. But just so you know that these are all related to treatment. I think a lot of times people feel that they've done something wrong. It's somehow their fault. These are incredibly common after treatment. It is not anything that you did wrong, and we can really help. Because we do know, again, that it continues into survivorship. So this is some of the research that I've done, is these are really high numbers. This is happening to a lot of female survivors, and we really want to make sure that we're reaching them because, again, it is treatable. And again, feel free to put anything in the chat that you would like. So we also know that there are physical changes for male survivors. And again, keep the same types of treatments that we see affecting female survivors are also going to affect male survivors. So things like chemotherapy, radiation, and surgery can really affect the functioning of the testicles. And so in this case, it's more testosterone that we're looking at. And there can be a lot of changes in testosterone kind of throughout treatment and then also longer term, which can lead to problems like erectile dysfunction. So this would be difficulties getting an erection, but also keeping an erection long enough. Difficulties with orgasm also can change things like sperm count, and there's a lot of fertility effects that we can talk about as well. So for example, testicular cancer is the most common solid tumor in adolescent and young adults, males. And so this in particular, the removal of the testicles can change the testosterone levels and can lead to difficulties with ejaculation and also, again, that erectile function. And similar to females, we know that this doesn't just go away. A lot of this can kind of continue for years. And I think one really important thing is that people are embarrassed to talk about it. They're not sure who to talk about it with. And I just want to make it really, really clear that these are late effects of treatment. They're side effects of treatment, just like anything else. And they're absolutely fair to talk to your doctor about. They'll also not have a ton of training necessarily in this. And that's when they send you to the sexual health clinic, because this is kind of the area where we do have a lot of expertise, and we're really comfortable. These are things we hear all the time. We're very, very comfortable talking about all of these things, so we're happy to talk to you about them. So I would say, so those are the physical changes. Those are kind of what people usually think of when they ask about kind of sexual function after cancer treatment. But the other thing, and to be totally honest, the most common thing that I hear is that people feel like their sexual desire is low after cancer. And a lot of times people will say, like, I just don't have any sexual desire. So I've heard so many young adults say, like, if no one brought it up, I probably would never think about sex again. And this is really hard because, if we think about young adulthood, that's when a lot of relationships are starting. Maybe people are trying to start families, have kids. And this is really getting in the way. It's getting in the way of connecting with other people and having the sex life that they want. So again, very, very common during cancer treatment and also after into survivorship. And I would say, at least 20, 30%. I would say this is actually a lot higher in what I see in the sexual health clinic. Kind of any type of diagnosis, people will say that they have changes in sexual desire. So sometimes, in some cases, it is really directly related to cancer treatment. So we know that lower testosterone in male survivors after testicular cancer, for example, could lead to low sexual desire. But again, I see it in all types of survivors where there aren't actually necessarily hormonal changes. And so it's a little bit more complicated than that. And we think it's actually related to things like mental health, body image, self-confidence, and just kind of the changes that are required as you go through cancer. So my big pitch on this is that it is not necessarily that the sexual desire is gone, it's that it's changed. So how I like to describe it is that it's changed from what we call spontaneous desire to responsive desire. Spontaneous desire is what you think of like in the movies, kind of like, they're talking and then bam, they're ready to have sex. There's no lead up, there's just out of context, ready to have sex. So that's like the light switch, like all of a sudden, absolutely ready to have sex, don't need any warm up. That's true for some people. To be totally honest, that is often not the case for many people even before cancer. But after cancer, what we see is that people really shift to this responsive desire. And so the responsive desire you can think of more as like a fire, has to be kindled. So it's not just gonna in 1 second be ready. You have to build it up. You have to figure out how to kind of cultivate it and build that fire. It's still gonna be just as good when you get there. It's just that it takes a little bit more work kind of on the front end. So one analogy that I really like is imagine you are at dinner. You've had a big dinner, you're really, really full. You didn't even think about dessert. You didn't even look at the dessert menu. And then maybe it's your birthday. And so the waiter comes over with your favorite dessert. You hadn't thought about it at all, but as soon as they come over with the dessert, you can see it and it's glistening and you can see the steam rising off of it. Maybe it's a lava cake. It looks incredible. As they get closer, you can smell it and your mouth starts watering. You take a bite and it's incredible and you love it. So the difference is you not once did you even think about lava cake. You didn't think about dessert at all. You didn't want it necessarily. It didn't even occur to you. And then all of your senses were really, really kind of awakened and involved, and then you really enjoyed it. And so it's the same thing with cancer survivors for the most part, is that you may not naturally kind of spontaneously think about it, but if you figure out what works for you, so it could be things like erotica, it could be porn, it could be a massage, it could be kind of date night, whatever it is to kind of get that going, then the desire is there. It just has to be cultivated. So again, feel free to jump into the chat with any questions. I know people tend to have a lot of questions about sexual desire. So another thing that's kind of unique to young adult cancer survivors is lack of sexual education. And so if you had cancer kind of during important developmental periods, you both maybe missed formal sexual education. And to be totally honest, sexual education is not fantastic in the first place. But you also missed informal sexual education. So a lot of times survivors will say, I was in the hospital for most of my teens. Like all of my friends were talking about sex and learning and looking things up. And I just, I was in a totally different world. So I feel like I just don't know. So it's kind of the basic sexual education that people feel like they missed. And then there's this other piece, which is the sexual education related to cancer. So you can see this quote, I'm worried that having sex will somehow hurt my ovary, which is scary because I only have one left. So this is a survivor that I saw who had had her ovary removed because of ovarian cancer. And she had avoided having sex because she was scared. What if physically having sex, bumps into the ovary, there's scar tissue or something like that? What if that means I stop getting my periods and I can't get pregnant? And basically really afraid of damaging that one ovary. And so we had to back way up. This is, she's in her late 20s. She had avoided sex for a really long time, had wanted to have sex for this whole time, and had just been too scared and had been unsure who she was supposed to ask. And so we kind of backed way up and said, nope, it's totally, absolutely safe for you to have sex, and kind of did a lot of the sex ed related, kind of just basic sex ed, as well as sex ed as related to her cancer treatment. Another piece of this is that people are really unsure about how to tell people about their cancer history. And so this happens a lot with young adult survivors, and people say like, I feel like I'm hiding it if I don't have it on my profile, but if I have it on my profile, then I get weird questions. And a lot of it really depends on kind of how obvious it is that you've had cancer. And so some people will say like, I have this huge scar from where I had brain surgery. I'd rather tell people ahead of time because I don't want to deal with them freaking out in the moment versus you really can't tell I've had cancer. And so they would never necessarily know. I have to eventually tell them. And so my first pitch is that everybody has something that they don't want to tell on the first date, and it's okay not to. I would really wait until you feel more comfortable. And so I work with people, with young adult cancer survivors, to come up with like a couple different levels. So maybe the elevator pitch is like, oh yeah, I was really sick when I was a kid. I'm doing a lot better now. I can tell you more about it later. That would be kind of for early stage dating. And then as you're starting to get to know the person, you can maybe say, oh yeah, I had leukemia when I was a kid. It's mostly, obviously I survived that, which is great, but there's all these kind of health effects. I have a lot of doctor's appointments, kind of frustrating. And then kind of as you get farther into a relationship, talking more in detail about it once you feel safe. Another thing that I see a lot is lack of sexual experience. And so I look at a lot of survivors, in their 30s who say, like, I just, late 20s and early 30s especially, who'll say, like, I just, I missed all of that. I was just trying to survive. And then I was just trying to figure out how to make friends. So you can see this quote, in high school, I was too sick and exhausted to date. Now I'm in my 20s and I'm scared to start dating because I'm embarrassed to admit I've never had sex. So a lot of times people, it's kind of a snowball effect is, you feel a little bit behind and then you're avoiding dating or sexual activity because you feel behind and you feel like you're the only one that's not sexually active, that hasn't had sex. And then that kind of keeps going, the avoidance gets harder and harder. And so what I always start with is, first of all, there's lots of people who haven't had sex yet, for lots of different reasons. And there's one case that we'll talk about later. Kind of the first person he ended up being in a relationship with also hadn't had sex, and she was in her late 20s as well, but for totally different reasons, not cancer related. And so really working on some of that embarrassment. And then also kind of working on, just like we did with the talking about your cancer history, practicing what to say if people have questions. And so saying like, explaining that piece is like, I was so focused on surviving, and then I was focused on making friends, and then I got to college and I was just trying to make it through college. And then I kind of woke up one day in my 30s and said, oh wait, I actually do want to date, but I don't know where to start. And so kind of how to explain that to partners and how to pick partners that are going to be able to take it really slow with you. So again, this is something that is really typical of young adults. I just want you to know you are not alone. It is, I'm doing research again where these quotes are coming from. I've been doing a lot of interviews with young adult cancer survivors about their sexual health. And this is one of the most common ones that people will say. And they're incredibly relieved to learn that this is a lot of the young adults that I work with. And the other thing that sounds weird is it is totally possible to learn how to date, and to kind of work your way up to sexual activity. It's not all or nothing. You can kind of figure out how to practice all these little steps about dating. You can learn how to do all these different pieces of dating that you haven't done before. So other things that I hear a lot about, a lot of body image concerns. So things like shame about scars, a lot of either hair loss. So hair loss often happens during treatment, for example, chemotherapy. But what's interesting is I hear a lot of young adults will say, like, yeah, I lost my hair. It took forever to grow back, but once it grew back, it was really different. So it might be really thin or kind of patchier. They're like, people always say, like, you're right, you lose your hair with chemo, but they don't ever tell you that kind of your hair might be different forever. And other things like weight gain, short stature, and immature breast development. So one thing that can happen is that if you have cancer treatment during puberty or during kind of important developmental stages, it can either delay or kind of interrupt development. And so I had one patient who she was trying to date. She was on dating apps, but she kept getting off because she kept getting kicked off because people would think she was a child and would report her because she was very short and her kind of the face and breast development had not kind of continued as expected because of some of the interruptions to puberty. And so we talked a lot about how the dating websites are really maybe not going to be appropriate for her because it was just incredibly hurtful every single time. She was in her late 20s. Every single time she got kicked off was really upsetting for her, and she wasn't meeting the right people. And so we talked about how it might be more helpful to do something like go to a board game meetup or other things where she could explain in person what was happening, and it would be a lot clearer that she, was in fact an adult. Another thing that really came up a lot in the interviews that I've been doing is people feeling kind of damaged or broken after treatment. And I think this came up in almost all of the 25 interviews to some degree. And so I just want to kind of normalize that at various points, people do feel like their cancer treatment has damaged them, and they worry that no one is going to want to date them. So I think that just normalizing this piece that most cancer survivors at some point feel like this. And also, I think there's lots of people who feel like this for various reasons. And also, young adult cancer survivors end up in wonderful relationships, wonderful, healthy relationships. Another thing that I see is people say, like, I could only another cancer survivor would ever date me because of this, because they understand and because, they're damaged too. So there definitely are some young adult cancer survivors who have ended up dating each other, some who have met at various programs of ours. And also there's lots who have met people who don't have a cancer history, but are really open to learning about kind of their experience and have been really supportive. So I think this quote really sums it up, kind of all of these other types of concerns that can get in the way of sexual health. So I only go on Zoom dates now, so no one can see how short I am or that I'm losing my hair. I don't have to see the look on their face when I walk in and see that I'm not really a man, but obviously I can't just do Zoom dates forever. And so this is a patient who is understandably having a really, really hard time with the body image concerns. And actually kind of the COVID piece had been helpful for him because he had kind of completely avoided dating before, but Zoom was a good step. And this was when he was trying to transition to going in person. But again, a lot of these changes, so kind of the losing the hair, and especially for men, I think the growth piece, feeling kind of shorter than their peers, has also been really hard. Those are all things that we can kind of talk about and talk about how to manage, and especially the body image concerns, very, very common. And then, as you get farther out and kind of work through those end up affecting people less and less over time. And the same thing with the negative self-identity. Okay. So those are all kind of the sexual health problems that could happen or that are most common. So what could sexual health treatment look like? So this could mean treatment with me. It could mean treatment elsewhere, kind of with another therapist who specializes in this. But I'll walk you through a couple different cases. So first, this is an example patient, Ashley. She was a 30-year-old brain cancer survivor. She had surgical resection at ages 15 and 18. And I like this example because it's a longer treatment. So we did 9 sessions, but it really goes through kind of outlines a lot of the different pieces that we can do in this treatment. So first she said, it breaks my heart to see people my age post about babies and engagements on Instagram. I want those things too. I just have no idea how to get there. How do you start dating when you're 30? And so she was really a great example of exactly what I was talking about as kind of, she was really sick in her teen years. And then she basically said, like, I finally figured out, I made it through that. I survived. And then I had to figure out how to make friends. And then I had to just make it through college. And that was hard enough on its own. And then I had to get a job and she has a really great job. She's really successful. And then that last piece of, okay, everything else in my life is kind of all set. Now I feel really behind in this other area. So you can see I have the biopsychosocial model, and I do actually go through these different kind of components with patients because I find it's really helpful in thinking through kind of the different parts that we can work on. So first, the biological or the physical aspects. So she had vaginal atrophy, which is a fancy word for kind of those vaginal dryness changes. And so because of some hormone imbalances, she was really related to what we call ovarian insufficiency. So basically her ovaries are not functioning as they should. And so her hormone levels are off, which leads to these issues with the vaginal dryness and vaginal atrophy. She had a lot of anxiety about sex and dating, a lot of avoidance, had basically completely avoided it because it really, really scared her and she didn't know where to start. Also had limited sexual education, so we'll talk about that, but it feels like she kind of completely missed the official sex ed, and then again, also missed all the just casual talking about it and learning. Something that is very common for young adult cancer survivors that you may experience is that it's really, really hard to separate from parents. And so as you may have experienced, or you can imagine, if your kid gets cancer, your parents tend to be a little bit overprotective. It's very hard for them, and so they hang on tight and they want to protect you forever. And for a lot of the young adults that I work with, that kind of continues well into adulthood. And so that was something that was really, really, really key in this presentation. All right, so what did treatment look like? First, we started with, I started by going over that biopsychosocial model. We talked about all the different pieces that might be helpful. And then we'll talk about this later, but we talked through kind of some of the physical pieces. And she had never had a gynecological exam. And so the reason that was important is that we really wanted to get a good handle on what that vaginal tissue, how healthy it was. And so I am not that type of doctor. And so I really wanted her to get seen by someone so we could know kind of how much vaginal dryness were we working with. She was very, very anxious about going to gynecology. So we did a lot of kind of talking about what that might look like, practicing, watching videos, things like that. So next, we really backed way up, and she was, really embarrassed to admit this, but she was like, I don't even know like sexual anatomy. Like I don't know where I've heard of the clitoris. I don't know where it is. Like, am I supposed to be shaving? I have no idea. And so we kind of backed up and just did some basic sexual anatomy and talked through kind of any of her questions. And again, I just want everybody to know it's normal to kind of have missed a lot of this stuff. And also, to be totally honest, there's a lot of young adults out there and just adults in general that also didn't know any of this. And I think that it's good to kind of back up and talk about that. So then we talked for her specifically of how her cancer treatment impacted puberty. And so what happened is that her first surgery kind of hit right after puberty had started for her and really interrupted it and really delayed it. And then she had all of these other symptoms that were related to that ovarian function that we talked about. And so I explained what's called, the fancy term is the genitourinary symptoms associated with ovarian insufficiency, basically just the changes in lubrication that we talked about, as well as vaginal dryness and other things like that. So I had her start with a vaginal moisturizer. She started with Recleanse, moisturizing inside the vagina and then around the entrance to the vagina. Once we heard back from the gynecologist that she did have vaginal dryness and that we should address that. The other thing that we talked about was something we call vibration therapy, which is a fancy word for vibrators. And so there's two reasons that we recommend vibrators. One is that after cancer treatment, as I mentioned, it can often be harder to orgasm, harder to reach orgasm. And all that means is just that those nerves are a little bit less sensitive. And so you need more stimulation. So it can be hard to kind of achieve that level of stimulation with like, mouth or fingers. And so the vibrators can really helpful with a partner or on your own. Highly recommend. My one caveat is that there's so many different vibrators. You can find them on Amazon. You can find them anywhere. The one piece of feedback that I've gotten is some of them are very loud. And so if you're looking for a quiet one, I would specify that. And there's a lot of quiet ones, but that's some of the feedback I've heard, especially if you have young kids or if there's anybody kind of around that you do not want knowing. So one piece is just helps with that sexual pleasure piece. And the other reason that it's actually kind of a rehab instrument is that the vibration brings what we call oxygenated blood flow to that tissue. And that's really important for healing it and making sure that it's nice and healthy. So the bonus is that it's fun, and also it's really helpful if you have things like vaginal dryness or vaginal atrophy. So that was the first piece. We just kind of talked about, we want to get the physical aspects all set so that when she was ready to start having sexual intercourse, that we would make sure that she felt really comfortable and that all of the tissue and the vaginal health was kind of all together. So again, this is just kind of reviewing all of the different pieces. And so again, just so you know, if you're a female cancer survivor, if anybody mentions genitourinary symptoms of menopause or after cancer treatment, this is what it means. It's vaginal dryness, vaginal atrophy. And the last piece that I haven't mentioned is some incontinence or urinary urgency. So feeling like you have to pee all the time. That can also be related to the cancer treatment and kind of that the ovarian insufficiency or changes in the ovary function. And so we'll be talking about the pelvic floor, but it's really related. So it's basically this basket of muscles that's called our pelvic floor. And it's connected to lots of important things. It's connected to obviously our pelvis, but also our lower back and all of our core muscles. It's a very important group of muscles, but it's not one that we know much about or kind of have natural control over. But one, it's really important for controlling kind of your bladder and when you release and tighten to control urination. And one thing that happens after cancer is that because that estrogen leaves the tissue, those muscles actually also get kind of tight and less flexible, and that can affect ability to kind of hold in urine when you want to. But the good news is that is very treatable. We'll talk about something called pelvic floor physical therapy that can address that as well as other concerns. Okay, so another type of pain that can happen. So there's the vaginal dryness, which can cause kind of that burning, ripping, kind of micro tear pain. There's a different type of pain that you may have heard of called vaginismus. But essentially what happens is that if sex is painful for whatever reason, those pelvic floor muscles kind of clamp down to try to protect you. So that's that brace and protect. It automatically tightens those muscles, and then it's more painful and it tightens again. It's more painful and tightens again. And what can happen over time is that those muscles and that tissue can get kind of stuck in its tight mode. And that can make sex very painful. So it's kind of a deeper, more like stabbing or muscular pain. And sometimes people will say like, I feel like my partner like can't even get in, like there's somehow like a wall there. And that's because those muscles have just kind of cinched down. So again, this is one name for this is called vaginismus. And the good news is it is treatable. And so what we do is something called pelvic floor physical therapy. This is something that you can do on your own, kind of with the guidance of a sexual health expert, or you can do it with a pelvic floor physical therapist. And the basic idea is that you have to learn how to kind of have control over those pelvic muscles. And you also have to stretch out the tissue and the muscles very slowly. So you can see these weird looking colorful tubes. Those are something called vaginal dilators. And the idea is basically what you do is you lay down, usually on your bed or something, put your knees up and insert, you start with the smallest and you insert the vaginal dilator into your vagina and you slowly kind of move it around. And again, it's trying to stretch that tissue and stretch those muscles. And then over weeks and weeks, you move up each size until you're at the size of either your partner or kind of an average partner. And again, that's helping kind of create, it's doing two really important things. One is that physically it's stretching out that tissue. And two, so that when you do have sex, you'll be able to have sex comfortably. And two, and honestly, equally as important, it's building confidence. It's really, really important to be able to know that when you have sex, it's not going to be painful. And so this is something I use the vaginal dilators with lots of people, even if they're not having a ton of pain or if they're not sure they're having pain. I use the vaginal dilators so that they're really comfortable again once they get to sex. So this is particularly true for people who have never been sexually active. I have a lot of patients who've never had sex or haven't had sex since their cancer diagnosis and treatment. And they're just really anxious about what it might be like. And so we use the vaginal dilators to get them to practice essentially, kind of get through the anxiety and the avoidance piece, and also physically know that they will be able to tolerate having sex. The other thing, it's also used with both men and women for, we mentioned the urinary difficulties, the urinary incontinence. And again, what it's doing is it's helping you engage those muscles, kind of tighten those muscles when you need to, for example, not pee, or release them to be able to either have sex or go to the bathroom. So again, it can help with vaginal atrophy, pain with sexual activity. It can also help with difficulty with orgasm in both men and women. So during orgasm, those pelvic muscles have to be loose to allow for sex, and then they have to tighten during orgasm and then they release. And so sometimes people will experience pain during orgasm because they're tightening too much and they get kind of stuck, and then they come down. So one thing is that usually the only time we hear about our pelvic floor is after pregnancy and birth. And people will say, just do some Kegels and tighten it up. So I'll have a lot of people come in and say, I know I'm having trouble with my pelvic floor, so I've been doing Kegels or I've been doing Pilates. And that actually can make those muscles tighter. So we do not recommend doing that. We really recommend working with a pelvic floor physical therapist. They're wonderful. We only send to people who specialize in working with people after cancer. And if I can get, people are nervous about going to them in the first place, but if I can get people to them, they absolutely love them. All right, so then sessions 4 to 7 really focused on the psychological elements. So again, we think about that biopsychosocial component. Right now we're on the psychological component aspect of it. So for Ashley, this was really related to a cycle of anxiety and avoidance. So particularly in the area of sex and dating. So we started what's called exposures to reduce anxiety around dating and sexual activity. So we kind of broke things down, you'll see, into different steps about creating dating profiles, going on dates, things like that. So this is something called a fear hierarchy. And this is, I'm also an anxiety therapist, which is helpful because in sexual health, there's a lot of anxiety. And the basic idea is that you create what's called a fear hierarchy, where you list all the things that you're afraid of, which everybody loves doing. It can be a little bit overwhelming at first, but it's really, really helpful. So you list all the things that you're afraid of doing. We break it down into really, really manageable chunks, from kind of the scariest thing to the easiest thing. And I'll have people, everyone's really freaked out about kind of the 8, 9, and 10. I say, don't even worry about that. We'll get to that. By the time we get there, it'll seem a lot easier. And so you can see for Ashley, kind of the easier things. So down at 1 and 2, download a dating app, take pictures for a dating app, create a dating profile, have a gynecological exam, message someone on a dating application. And so we did a lot of these either in session or she did it kind of in between for homework. So we, she pulled up a dating app and we filled out the profile together. One of her tasks was to take pictures because she didn't have any recent pictures, but she was also very anxious about having photos taken. And so she practiced on her own first, and then she had her friend do kind of a little photo shoot with her. And she was able to really slowly work her way up. And as she did, the anxiety got a lot lower about dating. And also, she was very proud of herself because these are things, again, she never thought that she can do. And I think the most powerful piece about a fear hierarchy, and you can do this on your own. I do it on myself for all sorts of things that I'm a little bit anxious about. So, for example, if I haven't, driven in a while after living in a city, I might be a little bit anxious about driving, and I might kind of create one of these lists for myself. Is like, first I'm going to try driving in the suburbs, and then I'm going to eventually work my way up to driving in Boston. But the most powerful piece is showing her that you could really break this down. That instead of this kind of black hole, this really scary, like I have no idea how to date, you can break anything down into steps, including dating. And so all she had to do was one step at a time, just message one person on a dating app. That's all. She didn't have to go on a date. She just had to message someone on a dating app. And so she was able to work through all of these different steps kind of in treatment with me. We did a lot of role playing, explaining the dating and cancer history. So in particular, she was very worried about not having sexual experience. We did a lot of practice on kind of how to explain that to people. We also, for that last component, the social or interpersonal component, we really focused on psychoeducation. So that's a fancy word for just talking about why there might be delays due to cancer. And so I told her, similar to how I've been talking to you guys about it, this is really common. It's really common in cancer survivors, and it makes a lot of sense. The development would get disrupted, and some of these things would kind of get delayed. And again, the other thing is that this is delayed for lots of people. I think particularly because of COVID, everybody kind of got delayed and now has a lot more understanding about a lot of these different things. So again, did lots more role plays. Another really important piece, as I mentioned before, is she really want to practice increased independence. So what was interesting is, so she lived with her parents, which is very common for a lot of young adults, but particularly young adult cancer survivors. And that had, kind of been working for her, but it was really getting in the way of her dating. And so we came up with, she really wanted to, this is not something I pushed, but she really wanted to ultimately live on her own and then eventually live with a partner. And she, talked about how I'm not sure how I can date. Like, I can't bring someone home. I have to walk past my parents' bedroom to get to my bedroom. That just feels very uncomfortable. And so this is something that she wanted to do kind of alongside this piece. So we walked through, we did the same thing. We came up with a whole list, kind of the scariest to the least scary. We practiced talking about it during session. She talked to her friends about moving out. She started looking for apartments. She talked to her parents about moving out. And one really important piece is understanding that parents also have a really hard time with this. So as I mentioned, if your kid gets cancer, any age, but particularly on the younger side, you often become very protective and kind of what we call helicopter parent. Sometimes they'll describe themselves as still very involved in everything and really anxious about kind of their safety. And so she, she would say, like, I would go on dates and they would call me all the time, or they would have to drop me off because I can't drive. And so it was just really making dating really difficult. What was interesting is that they also had a really hard time thinking about her moving out. And so she came back one session and said, I suggested moving out, and they said, oh, we could just build you a condo in the backyard. And she's like, oh, this is a perfect idea. And she gave permission to share this story. And she came back, and then we talked through, and she's like, oh, but I would still have to walk past their window to get to the condo. They would still see everything, and that's not actually what I want. That was a very thoughtful idea, but it's really just showing that this is hard. This is process for everybody. It's hard for young adults to become more independent. And so we kind of worked through, the parents also had to work through their own anxiety about that as well. All right, so we did 9 sessions. By the end of the 9 sessions, Ashley was dating for the first time. Her anxiety was significantly reduced around sex and dating. She was able to get a pelvic exam, and she had started pelvic floor physical therapy, which was going great. She had also increased her independence. At that point, she had looked at, I think, about 5 apartments and was getting ready to choose one of them. I think this quote sums it up. So she said, I'm not the person I was when I started therapy. I felt like a girl. Now I finally feel like a woman. I had two brain surgeries, but this therapy saved my life. And so she really just felt like, she was kind of on hold and that she wasn't going to be able to move past these things. And this is a little bit longer than sexual health treatment often is. But in terms of, mental health treatment, that's very short. 9 sessions is very, very short to be able to kind of see all of this progress. So I'm going to take a quick break and see if there are any questions that people have. Otherwise, I have um, a couple more examples that I can go through. Looks like no questions. All right, so the next example I have is Michael. And again, so as just a general, these are not real patient names. These are a kind of a combination of patients that I've mashed together so that you can't tell who they are, just to make sure that we keep their privacy intact. So this is a 24-year-old testicular cancer survivor. He had his right testicle removed at age 18, and this was a much shorter kind of version of therapy. So you can get an idea of what it might look like kind of on the shorter end. So Michael says, I just started dating and I feel like everyone except for me knows what to do. I've been on so many first dates, but I can't turn them into a relationship. So again, the biopsychosocial model, he had his right testicle removed. That actually ended up really not affecting his sexual health too much, other than a little bit of pain with masturbation, which we'll talk about. But it really didn't affect his hormone levels. His testosterone was normal and everything. Everything kind of related to that was fine. He was experiencing pain with masturbation that he wasn't sure if it was related to the surgery or we'll talk about kind of frequency of masturbation. He had a lot of anxiety about disclosing his cancer history, and he felt like he had very limited dating experience, especially kind of in getting past that first date. And so again, all of this combined to make it really difficult for him to get into long-term relationships that he was interested in. So the first session was talking about kind of the physical aspects again. So I had had him meet with his surgeon to ask about the pain with masturbation. And basically the surgeon said, you shouldn't have any pain. I don't think that's what is causing it. The scars look great. There's no reason to expect pain with masturbation. And then it turned out that he was actually masturbating for several hours a day. And the pain with masturbation was actually much more related to just the frequency of masturbation. And I think I was really proud of him for sharing this with me because he hadn't shared it with his surgeon or with any of the other medical providers. And so this is a really good opportunity just to normalize masturbation frequency. And so we talked a lot about kind of what is normal and appropriate, and our kind of the line for sexual health experts is that as long as it's not physically hurting you or getting in the way of things that you need to or want to be doing, then it's not an issue. So for him, we realized that it was actually hurting him. And when he reduced his masturbation time, the pain went away. But that was really important for him to kind of be able to talk about it and tell someone how much he was masturbating, because then I'm sure the surgeon would have also said it might just be the frequency. So really just normalizing that. And we also realized that he was really kind of using masturbation as an avoidance strategy. He wasn't engaging in other things. He wasn't, seeing his friends as much. He wasn't doing as much work. And so talked about reducing that and increasing some of these other activities that were going to help him more. So that was the first session. And then the second session, or we also in that first session focused on psychological components. So again, practicing talking about cancer history and really thinking about kind of what thoughts are driving all of this anxiety. And for him, is a lot related to no one's ever going to want to date me. I'm never going to be able to find a partner. Everyone else has so much experience. I'm not sure what I'm going to be able to do. And so you can see this, it's called a 3-component model. So going through kind of the thoughts, feelings, and behaviors. So again, everyone else feels comfortable dating. I'm too far behind. I'll never learn to date or find someone I actually connect with. Everyone else has so much more sexual experience than me. And all of those really negative thoughts, of course, made him feel anxious, embarrassed, hopeless, jittery, and he had stomach aches. think it's spelled wrong. And then the behavior. So kind of those negative thoughts and those difficult feelings led to just messaging everyone. So he would literally message every single person he came across in a dating app. And he would also kind of craft his image to basically like everything. And so what was happening is that he wasn't actually meeting people he connected with because his net was too wide. He was just so interested in making a connection that he was trying to connect with everyone and really not able to do it. And so we worked a lot on figuring out, kind of again, talking about why he might have some of these delays, that it was normal. It's normal in young adult cancer survivors. Honestly, it's normal in young adults again, in general. And then we also talked about kind of strategies to find a compatible partner, and that really wasn't surprised that he had not connected with people because he was trying to connect with everybody. If you try to connect with everybody, then you're really not going to connect with anybody. And so narrowing it down to figure out what was he actually interested in, what would he like to share with a partner, and how could we craft kind of his dating profile and also his messages so that he could narrow the field and make it much more likely that he was going to be able to move past that first date because it was going to be someone that kind of he had mutual interest with. And again, we also did a lot of role plays to practice talking about cancer history and limited sexual experience. He really thought that he was completely alone in not having a lot of sexual experience and was really embarrassed about it. And then what ended up happening is that, again, this was 2 sessions, and that was really all he needed to just kind of reframe, to really work through the shame about the masturbation, reduce that, and come up with a different plan for his kind of his dating. So he says, I can't believe I'm finally in a relationship. Once I started talking to my current partner about my cancer and dating history, it got so much easier. I didn't realize she might be anxious and not have a lot of experience either, just for different reasons. So again, really reinforce the idea that this is really common and is not a deal breaker for most people. And so I think this is a good example of sometimes you just need kind of some of your questions answered. You don't need a long course of treatment. You just need somebody to help guide you a little bit to figuring out, just letting you know that this is possible, and that a lot of people have gotten through this. All right, so I don't know if you guys want me to do. I have one more case, or I can stop now and we can wrap up. I don't know, Sierra or Lauren.
We still have a few minutes if you want to keep going. We don't have any questions at the moment.
Okay, great. All right, so this is the last case. This is Sonia. So Sonia was a 23-year-old Wilms tumor survivor. She had surgery, chemotherapy, and abdominal radiation at age 3. And I like to present this case because I think it's really important. People don't realize that even if you had cancer really, really early, way before puberty, it can actually also really affect a lot of these physical, psychological, and social aspects. So for her, it was really related to fertility. So she said, I'm broken. None of my friends have problems with sex or getting pregnant. I feel like this is my fault. So she had ovarian insufficiency. Again, her ovaries were not functioning kind of as we would expect for her age. Related to her cancer treatment, particularly the abdominal radiation. So basically, when she had radiation at age 3, it affected her ovaries and the development of those ovaries. Because of this, she had vaginal dryness and then also infertility. So she knew that she was definitely not going to be able to get pregnant. So there's a lot of distress about the infertility and a lot of shame about the infertility and also about the sexual dysfunction. And then socially, there was a lot of family pressure to conceive. So particularly from her in-laws, she was getting a lot. She's also very young, particularly to be getting this much pressure, but was getting a lot of family pressure to get pregnant. So first, we started with the biological treatment components. So again, I provided psychoeducation on ovarian insufficiency and vaginal dryness. I referred her to gynecology. She hadn't been to a gynecologist. And again, we just really wanted to get kind of eyes on that vaginal tissue to see what the status was and see if we needed to do to kind of do anything with vaginal moisturizer, which we did end up which I did end up recommending. And then the other piece, and for this case, really she needed the vaginal estrogen because her hormone levels were just so low, and she really ended up needing the vaginal estrogen to make that tissue healthier. So then for the psychological treatment components, we talked a lot about first coping with the stress related to sexual desire. So she was really kind of embarrassed that she's like, I'm a newlywed. I should be wanting to have sex all the time. I don't understand. All my friends are having sex all the time. I think turns out she actually had not talked to them. And when she did talk to them, some of them were also having some of these same problems. She's like, I'm 23. I should be wanting to have sex constantly, and I'm not. My husband's being so good about it, but I just, I'm really embarrassed. And so I explained the changes in sexual desire, and for her, because she had cancer so young, she had only ever had this responsive desire, and she didn't know that lots of women have that kind of just naturally, and there wasn't anything wrong with her, but she didn't know kind of what to do about it. And so we talked a lot about. You can see this handout that I give people, kind of how to cultivate sexual desire. It's not just going to be there naturally or spontaneously, and so we have to kind of help it along. And so talked about erotica. We talked a little bit about porn and how, she never really watched porn because it's not really necessarily made for what works for women. And we talked about there is porn that's made for women, and in particular that things like romance novels or erotica tend to work better, and kind of walked through some of her shame around that piece. And she ended up, being interested in trying some of those options. And then we also talked about coping with the stress related to infertility. And so a lot of processing grief is that this is a loss, that she is not able to carry children that she wants to, and that this is something that she lost because of cancer, and really allowing that to be a grief process. Had been feeling, kind of guilty that she was feeling upset about it, and that she couldn't have kids. So we did a lot of processing around that piece. And then we really focused on assertiveness training. And so a lot of role plays practicing assertiveness when experiencing pressure about fertility. So kind of just normalize that this is absolutely inappropriate for her in-laws to be pressuring her about having kids, especially because they did know that she was not able to. And so we did a lot of practice on kind of what to say to them, how to set limits, and then also working with her husband, because this was his family. And so how is he going to set limits with them, and really push back on we do want to have kids, please stop asking her. That this, she can't do anything about it. She wants to. We're working on adoption, but really kind of putting some boundaries up about that piece. And that was really powerful for her because it didn't even occur to her, that her in-laws, were doing anything not helpful, and B, that she could stand up for herself in an appropriate way. So for Sonia, I did 3 sessions over 2 months. She, because of the lack of sexual desire and the pain, she had really been avoiding kind of having any sort of sexual intimacy, or even like snuggling, kissing, anything like that. So we increased that a lot, increased sexual desire, made progress towards adoption, and was starting to use the assertiveness strategies. So she said at the end, I'm still upset I can't get pregnant, but it's such a relief to know none of this was my fault. I didn't realize how much our fertility issues were getting in the way of sex for us. Now I'm working on sex just being about sex. And so again, really powerful, not that many sessions, but was able to work through a lot of these issues. So the last piece is, I mentioned, so here are some different, I mentioned I'm part of the sexual health clinic at Dana-Farber, but here are some other kind of areas that you could look into, and what they might be able to help you with. So feel free to check out any of these individuals. And then the last thing is that, as I mentioned, I'm doing research on this area. So we know that there is not a good questionnaire for screening for these issues, which is a huge problem, because it means that they're not getting caught and treated. And so I'm working on creating a questionnaire. And as part of that, I am interviewing young adult cancer survivors, basically to ask, like, do you like this question? Is it getting at what your concerns are? So feel free to reach out if you're interested in participating. I would be meeting with you just to ask questions about those items, and then you get a $50 gift certificate. All right, and that is all for me.
Thank you so much, Dr. Chevalier. That was a really great presentation. It looks like we don't have any questions in the chat right now. To our live audience, if you have any questions, please put them into the chat so we can ask our presenter. But as mentioned earlier, this session was recorded and it will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as on the survivorship website. Thank you so much again, Dr. Chevalier, for that really informative presentation.
Awesome. Thanks, everybody.